Thanks so much, Rich. So our next speaker is the founder and director of the UPMC Headache Center, which has developed into the most active clinical headache program in the country. And his teaching skills has earned him many awards, including the prestigious Healthcare Provider of the Year Award from the National Headache Society. Thank you.
Thanks, Janet, and thank the organizers for the invitation to speak this morning. It's a pleasure to be here for another one of these meetings, and I'd like this to be interactive. I know it's a little more difficult when you are virtually interacting with me, but interactive. I'm going to start off with a quote for a reason. So it was the best of times, it was the worst of times. So that is pretty apt when it comes to describing what we see with headache overall in pregnancy. So this is a very famous painting, and again, I would ask you to think about it. Some of you may know this painting. So this is from Delacroix. It hangs in the Louvre, and this is Liberty leading the people. So Liberty holding a goddess, holding in one hand the flag, and the other hand the musket, representing the charge at the time of the French Revolution. So the best of times and the worst of times certainly references back to a specific quote, right? I think that most of us probably remember from maybe either middle school or high school, and I would ask you where that quote is from or who it is from. And without the need for response, we'll move further. I know we have a lot to cover, and I don't want to lose my head. Okay, so there is lots of information when it comes to headache and pregnancy, so we're going to have to focus a little bit. And the focus won't be on the secondary headaches. I'll touch upon them, but we have so many people today to tell you about the worst of times when it comes to stroke and brain tumors and other bad things that happen that involve headache and women who are pregnant. But my charge is to really maybe give you a little more updates of what's happened maybe in the past year or two, and then also to give you some practical management tips. So pre-pregnancy counseling. What do we do in advance? So it was the best of times, it was the worst of times, and people think that's where it ends. It's actually a very long quote. So this continues, you say, it's the age of wisdom, it was the age of foolishness, it was the epoch of belief, it was the epoch of incredulity. It was the season of light, it was the season of darkness. It was the spring of hope, it was the winter of despair. And it's not done. But moving on, primary headaches in pregnancy. Interestingly, here's some elements of despair. Women are afraid. Women with primary headache are afraid that their cluster headaches, their migraine headaches are going to worsen during the course of pregnancy. So they're afraid of that, and they're also afraid of, what if I need to treat? I don't know if I can be pregnant and not take my medicine. So what if I need to medicate? What's that going to do to my baby? And primary headache is a common problem in pregnancy. So 10 to 17% of pregnancies are complicated by primary headaches that develop or worsen during the pregnancy. And both the headache and the treatment has an impact. And we always focus on the treatment, the negative, the teratogenicity, the problems with the medications, but we lose sight of the fact that the headache has impact on that woman. That headache has impact on her workplace and her family. And that headache has impact on the health of the pregnancy. So tension headache is the most common headache that we see in the population. Not surprisingly, it's the most common headache to complicate a pregnancy. But migraine is the most common clinical headache in the population. 90% plus of all headache presentations to clinicians involve migraine, and that's not any different when we see pregnant situations. So in advance, we'd like to maximize everything we can do that does not involve drugs, right? What can we do to help? And then whatever medications need to be adjusted are adjusted. And then finally, we educate women on, particularly with migraine, since this is the dominant headache we're going to see, what is the impact of migraine on the pregnancy, potentially, and what's the impact of the pregnancy on the migraine. So this is the straightforward stuff. We preach this each and every day to all our patients about maintaining headache hygiene. So I don't care if you're a post-concussive headache or a cluster headache patient or a migraine patient, this is a rule of thumb to focus on regulating the nervous system. The more regular you keep the nervous system in terms of lifestyle, the better it tends to do. So what we see here is schedule regulations, your sleep patterns, your meal patterns, your exercise patterns. Hydrating, that's really important. Now, what happens in pregnancy, obviously, is, let's say hyperemesis occurs. Well, what happens to hydration? What happens to nutrition? What happens to exercise and sleep? So the impact of pregnancy is going to impact the ability of a woman to do many of these things. But regulation is really, really important. We try to minimize caffeine and analgesics, and obviously watch your triggers. What about magnesium? So this is a hotter topic more recently. So this is an update. I mean, magnesium flows like water in our clinic. And if you take too much of it, you might flow like water, maybe in a way. So the main side effect is diarrhea. So we limit it in patients who happen to have IBS, diarrhea predominant IBS, or patients who happen to have kidney disease or intolerance to it. But magnesium was something we thought, oh, it's safe, everybody should take it. We love using it in just about every patient we see, and we advised it. And then, there's the study that came out a number of years ago with the IV magnesium sulfate, and that over a prolonged period of time of more than 5 days of exposure, there seemed to be an association with bone demineralization. So then there was a Cochrane analysis that followed and said, well, it doesn't look too bad in terms of oral magnesium. Maybe, though, there's a slight increased rate of neonatal death. But a number of observational studies have been done, and we've looked at lower doses because we often preach higher doses, meaning 500, 1,000 even. And so lower doses, if you look at lower doses, and particularly doses up to 350 milligrams, they can be pretty well tolerated. It looks like that's safe. So now the general recommendation is you can take up to 350 milligrams. We happen to like certain preparations that are powders or gummies. You can titrate on smaller amounts rather than these big, particularly again, if you have hyperemesis or an upset stomach, a big magnesium tablet is sometimes hard to swallow in more ways than one. So what about other supplements? Well, CoQ10 is considered to be safe, but there's no data for prevention in the situation of pregnant women with migraine. But riboflavin, one that's often used, and some of these get started on this when they're kids, really hasn't been studied, and it's not considered that it's safe at that dose of 400 milligrams a day. And certainly herbal remedies, no good data to say that they might be safe, so we tend to avoid them. Behavioral approaches like biofeedback or cognitive behavioral therapy are very effective, but tend not to be practiced. They're expensive to access and difficult to access professionals who can train you. They are time consuming, but they can be very, very beneficial, and perhaps some innovations in smartphone technology are going to help us with this. I think that this is going to be much easier to pursue in the upcoming 5 to 10 years. Acupuncture, hypnosis, chiropractic care, there's really no data on other non-traditional approaches at this point. So secondary headaches in pregnancy, as I mentioned, I'm not going to focus necessarily on the subtypes, but here goes the quote. I mean, so Dickens went on for a long time at the opening of this Tale of Two Cities, right? So again, whether it was grammar school or middle school or high school, you probably remember the opening, but this continued. And actually, when you read it, it has a lot of interesting parallels to today. We had everything before us. We had nothing before us. We were all going direct to heaven. We were all going direct the other way. In short, the period was so far like the present period that some of its noisiest authorities insisted on its being received for good or for evil in the superlative degree of comparison only. So very, very interesting prose that, again, was referencing the French Revolution at the time. But, and the two cities, I always like to open that. What were the two cities? I think we all can remember the one, but what was the other one? I mean, Paris obviously was the important one. And then you think, what was the second city? And for those of you to not leave you hanging, it was London. Okay, so we first start off primary versus secondary headaches. This is innate to all of us managing headache patients. But to focus on pregnant patients, migraine and tension type being the two most prominent primary headaches, and then the secondary headaches, again, you're going to hear a lot about today. I'm not going to go into the specifics of tumors or preeclampsia or stroke in the situation, but I'll come back to it a little bit, particularly the stroke and preeclampsia situations when it references migraine shortly. So the secondary headache red flags, there are a number of them, and two that we really would say are appropriate here to focus on. One, progression or fundamental change in pattern. So migraine women come into pregnancy with migraines, and if it changes significantly. So interestingly, one point about brain tumors. The most common presentation of a brain tumor headache is a patient has more of the headaches they were having previously. If they were a tension headache prone, they're going to have more tension type headache. If they're a migraine prone, they're going to have more migraines. So you can't look at, and in fact, it's more commonly tension type because that's a more common headache. So we look at, did your headaches change? Are they different? And then high-risk clinical settings. This, we think about cancer, immunosuppression, HIV, but we also deal with pregnancy as a high-risk situation when it comes to the nervous system in many ways. So you're going to have more in detail discussion about neuroimaging. What we typically do is MRI, and we often will look at the opportunity of vascular imaging as well, MRA or MRV when appropriate. CT rarely, in an acute headache setting perhaps, but MRI is going to be your imaging modality of choice in this setting. Lumbar puncture occasionally, and then EEG is rarely necessary unless there's alterations in consciousness which suggest potential epilepsy. We have different labs, though, that we look at in pregnancy that we don't necessarily do in a standard patient who comes in with migraine. So pregnancy-specific labs, platelet counts, CMP with liver functions, the CRP, and urinalysis with protein measurement. So that's a little different from our general approach, which is we don't usually order any blood work, except if you have somebody over the age of 50, you screen them for temporal arteritis or giant cell arteritis. So you have a ESR, CRP ordered, but typically we don't do this. All right, so screening for secondary headaches. 5% of pregnancies are complicated by a new headache. So that's a lot. And somebody's going to say, so you're going to face this. You're taking care of women who are pregnant. You're going to face this. I never had this before. So if you look at what happens in that particular setting, when somebody comes in with a new headache, 140 women over 5 years, and Robbins, this is done at Montefiore, 56% of them present in the third trimester, which makes you a little nervous, right? This is where you start getting, okay, the third trimester and right after delivery is what makes at least headache neurologists very nervous when it comes to women in that setting. Turned out 65% had primary headaches and 91%, again, migraine. Secondary headache was 35% of the group, and 51% had hypertensive disorder of pregnancy. Factors associated with secondary headache, look at that. Hypertension had a 17-fold increase. So if you have a new headache or different headache, and you have hypertension at the time, this is a major red flag, and the major red flag, at least in this particular trial. Obviously, if you've never had headaches before, if you've had a seizure with a headache, if you have fever with a headache, abnormal neurological examination, and the long primary headache duration, it's atypical. So a migraine sufferer, typically it's 4 to 72 hours. Somebody will say, I've had it for a week or 10 days. So something that looks a little lengthy. Another study from Italy looked at 151 women over 6 years. Again, 58%, the dominant. So about 60%, we take these two studies together, about 60% come in with primary headache, about 40% with secondary headaches. The fever was listed on the prior from the Robbins study, and also you can see here in this particular study, acute infection was let's say sinusitis, was also a reason for headache in this population. So fever, and when we look at the secondary headache independent predictors, a baseline secondary headache, if you came into this with intracranial hypertension, you're going to get more headaches. If you came in with elevated blood pressure, fever, or an abnormal neurological examination, again, things we saw with the last trial, those are the patients you're going to be particularly attentive to. And if you look at those who just say I have headaches and they get imaged, this was 50% of the population there, symptomatic pathology was found in a quarter. And so that's a lot. And the risk of the pathology on scanning, first trimester headache, strong pain intensity, reduced level of consciousness, and seizure. All right, this is the storming of the Bastille. So we need to rise to the challenge of looking at migraine and managing it, I think, more aggressively with better comfort with some of the treatment strategies that we can deploy. So also from the text, a day wasted on others is not wasted on oneself. Isn't that what we all spend our days doing, right? Our careers are spent taking care of others, and Dickens recognized maybe that's not a bad thing. So we all know that migraine afflicts women more than men, right? Estrogen exposure does change the dynamic and also the age group. But look at where migraine is most active is exactly in the wheelhouse of where we're going to see women become pregnant. I'm not going to spend too much time on the criteria. There are formal diagnostic criteria from the International Classification of Headache Disorders that we still use, and they appropriate are in and outside pregnancy. So let's look at pregnancy impacting migraine, right? So how does pregnancy affect the course of migraine in a woman? Well, new onset migraine complicates 1 to 10%, and most of these occur in the first trimester. So the first trimester is a time of hormonal change. The migraine brain doesn't like change. We talked about schedule regulation a bit earlier. So the migraine brain does not like change, so hormones changing can certainly bring on more attacks or development of attacks. And then new onset of aura. So new onset of migraine headaches, yeah, you think a little bit about imaging, then you get new onset aura, and the woman really gets nervous, particularly if it gets beyond visual aura. So visual aura, and you get a kaleidoscope for 30 minutes that comes in your periphery, and then you get a headache that follows. And then if you had one on your right side and you had one on your left side, over the course of a few weeks, you're not going to be too nervous about that. But if you have a kaleidoscope that then turns to numbness in your hand and face, that then leads to aphasia or dysphagia for a period of time, that is going to be something that people are going to get more nervous about, particularly if it's not followed by headache. And interestingly, it's older men and pregnant women where we see aura most frequently not followed by the headache. So it's not unusual at all to see aura isolated. 80% of those with migraine will continue to experience attacks through the course. So it's about a 20% then quiet down pretty nicely. But overall, 80% will say, yeah, I've had some at least through the course of the pregnancy. 75% though show improvement, and most by the third trimester. Those that get worse in the first trimester, as mentioned. That's the time where hormones are changing most dramatically. And that's also the time where potentially this issue of hyperemesis becomes relevant, right? Impacting the regularity of schedule discussed earlier. So what can I tell a woman going into pregnancy? What can I tell her about her migraines? Well, I'll tell her one thing. If you have migraine without aura, you're likely to get better. If you have migraine with aura, it's a 50-50 proposition. Flip a coin. So migraine without aura, good odds. 85% you're going to get better, particularly second and third trimesters. Particularly, I usually tell people after the time of ultrasound, 18 weeks, 20 weeks. That's the transition. That's the phase where things start to get better. So I wouldn't say necessarily just second and third trimester, about halfway point. Onset of migraine at menarche and the history of mentally associated migraine. No, that's a no-brainer. You have headaches with your periods and you don't have periods, you don't have headaches as much. So that one is also a relevant factor. So if you had migraine onset with puberty, if you have migraine with your cycles, and if you have migraine, all three, migraine without aura, that's the trifecta. If you have migraine with aura, or you have any of these issues, if you've been pregnant a few times before, maybe it's a little more likely you're going to have headaches through. So if your third or fourth pregnancy, you can't just skate by and say, oh, my first one was great. I know my second one's going to be great. Or my third one's going to be great. Not necessarily. Hyperemesis, again, a factor. And then any type of other things that complicate the pregnancy. Again, I don't know how much that's directly impacting migraine or indirectly impacting migraine because it affects the other things I'm trying to get a woman to do, which is eat, sleep, exercise, and hydrate regularly. So here is the migraine without aura curve. Pretty good, isn't it? So the improvement is very consistent, and you see this, that most women, and then by the end of this it shows you 87%, but about 85% chance of this getting better during the course of the second and third trimesters. Migraine impacting pregnancy. So this is a reverse, right? So this is bidirectional. Pregnancy can affect migraine, migraine can affect pregnancy. Well, there's no increased risk of fetal malformation. So we can tell a woman, there's no greater chance of you having a baby that has some type of malformation. However, the news is not always good. Again, the best of times, now get a little bit of the worst of times. Worst of times is the vascular things are more likely. Now, gestational hypertension, which is great because we're going to worry about headache and hypertension. And then preeclampsia and eclampsia, higher odds ratios for women with migraine versus those that don't have migraine. So that's relevant. The other three, ischemic stroke, myocardial infarction, and thromboembolic events, actually doesn't matter if you're pregnant or not. Having migraine, particularly migraine with aura, women with migraine, or particularly migraine with aura, will have increased rates of all three of those, stroke, MI, and thromboembolic events, even outside the context of pregnancy. So pregnancy may raise the stakes, but those three are no surprise. Obviously, the first two are specific to pregnancy. Migraine impacting pregnancy in another way. What about withholding treatment? Again, so now a woman doesn't want to treat, or a lot of times the clinicians don't want to treat, and then we're left with inadequate acute treatment, which leads to low caloric intake, dehydration, and electrolyte imbalances, which aren't necessarily good for pregnancy. So that migraine can impact the pregnancy that way. And then the inadequate prevention, you have work absenteeism and presenteeism, increased rates of mental health issues like anxiety and depression and insomnia because the nervous system is agitated. There's so many headaches that there are repercussions to undertreatment. Now, we don't want to overtreat, certainly, but there's undertreatment does not have necessarily no negative outcomes. So when we're discussing this with women, what we're always doing is saying that we're not just giving you the risks of treatment and that's it. You have to have the risks of treatment and then the treated headache versus the risk of no treatment and the untreated headache situation. And that's where the balance comes in. We focus too much on the meds and not enough on what if we don't med. So this is also a very famous painting from the time. This is from David, Jacques-Louis David, who did, this is the tennis court oath. So this is a very famous event in the course of the French Revolution. You may remember from your history days that there were three estates. The first estate was the clergy, the second estate was nobility, and the third estate, the lessers, the commoners, which were 97% of the population. So therefore, the 1 to 3% of the clergy and nobility held all the power and the money, and therefore that had a lot to do with what happened with the French Revolution. So this is the tennis court oath. They were actually, the third estate was locked out. They were supposed to meet with the first and second, but they were locked out of the meeting room. So they met in an indoor tennis court at Versailles. It wasn't the Palace of Versailles, but it was in Versailles. And so this is the tennis court oath, and you have, again, members of the clergy that ended up coming here, and you have both a priest and a Protestant minister that are attending this particular meeting. So it was considered to be a pivotal point in the advance of really stress for the actual revolution itself. A wonderful fact to reflect upon that every human creature is constituted to be that profound secret and mystery to every other. If only we could kind of, again, how apt is this to our times today? You know, written centuries ago. And going through this text, you just think, wow, is he writing about now? All right, so now, practically, what are you going to do? So let's reconsider safe options. I've already maybe given you some ideas about magnesium and where we stand with that. Well, acetaminophen, no fetal anomalies, but what about this other stuff? Increased rates of asthma and ADHD in children. So should we worry about acetaminophen? Next, what about ondansetron? Okay, that used to be, boy, acetaminophen, ondansetron, magnesium. That would be the go-to, right? That's where you would, well, I don't know about the ondansetron makes me a little more nervous than it ever did. So there's data now from the birth defects research publication you see below from 2020. It's a more recent publication that really looked at ondansetron and said, maybe we should rethink ondansetron. So our acute migraine medications, we look at evidence on the left and then FDA, the old kind of system of pregnancy ratings on the right. I think some of us still kind of think in these modes. At least it's valuable to kind of relatively discuss the information with patients. you look at that and you say, well, we only have really one D, and that's high-dose aspirin. We got a lot of C's and B's, so we feel pretty good about that list. We have new things, and this is the G-PANTs. So this is the drugs that are being, you watch television, you're going to see one of the Williams sisters and one of the Kardashians, and I can't tell you which Williams sister, and I can't tell you which Kardashian, I can't tell you which drug, but they're telling you to use these drugs. And I think actually Whoopi Goldberg, I think, is taking one of these or something like that as well. So many celebrities will advocate these. I would not necessarily advocate them during pregnancy. They are small molecules. They've not been studied in pregnancy, and there is certainly, because they're small molecules, they're getting across the placenta. So the new G-PANTs, I would say, is you keep it in the pocket of your pants. Do not use these during pregnancy. What about preventive medications? Well, this list doesn't look quite as favorable, does it? We had some B's and C's. Now we got a lot more D's. This is a report card. That's not one you want to take home to your family, right? So D's and C's. Okay, none of us, hopefully in this room or online, had this, or I suspect you wouldn't be in this room or online at the time. But what do you do with this information? And then we got new stuff here. I don't know anybody. I don't think they're celebrities. They just have nice commercials that people are doing fun things because their migraines aren't bugging them as much. But these are the big CGRP monoclonal antibody. This addition to the class of migraine prevention has been a huge advance. They have really revolutionized what we've done with frequent episodic migraine and chronic migraine. They work great. They're big molecules, really big molecules. They're monoclonal antibodies. So the question is, are these safe? We don't know. Theoretically, they might be. But they could certainly impact the placenta itself and CGRP and blood flow at the placenta level. So we don't think they get across the placenta, but they could affect the placenta. Right now, they're still not recommended for use in pregnancy. This, though, we need to do more of, particularly the top one, pericranial nerve blocks. These are easy, these are effective, these are safe, and we don't do them enough, honestly. We use lidocaine instead of bupivacaine because of just the different rates of issues with pregnancy. So lidocaine seems to be preferred here, and you just mix it with a little normal saline. If it's steroid, that's your your option of choice if you need to add that. Onabotulinum toxin is something that we also use as well, and it has some data. Again, big molecule, probably doesn't get across the placenta. And we've seen greater and greater comfort. For those women who are afflicted with chronic migraine where other things haven't worked, we see greater and greater comfort with continuing this during pregnancy from our OB colleagues. There are devices that are fancy. They look good. They make you look really like modern. I'll show you a couple of these. The two we use most commonly are the supraorbital nerve stimulator and the remote electrical neuromodulator. These are ways of addressing prevention, the top one, and both prevention and acute. So the supraorbital nerve stimulator does both, has two settings for prevention and for acute. And then remote electrical neuromodulator or stimulator is only for acute. So that's the Cefaly device. That's the first one, the supraorbital one. Looks pretty nifty. So that's the smaller version of the one they used to have, which was much larger, more tiara appearance. This one is more localized. It's like a TENS unit, basically, ways to think about it. So we think it's safe, and if you really wanted to look at this way, is one way to try to settle a nervous system down without using meds. And this is the remote electrical stimulation, the REN, or the Nerivio Migra device, which is this little thing you just put on your arm, and that's something that you activate with your smartphone during the course of a migraine attack to try to turn it off. So these, again, there's no studies in pregnancy. We can't commit to safety, but it's reasonable to believe that, and speculate that they will be safe. So where do we end this? Acute migraine. So acetaminophen is still probably our best option, right? It has flaws, but those flaws are certainly minimal compared to other ones. And we add metoclopramide. Okay, I think that at this point in time, there's clearly now with the Zofran on Dancitron data recently published, I think this is a no-brainer now. So this is metoclopramide with acetaminophen, diphenhydramine can be added. You basically got category B medications across the board. This is safe. This is something that you could do also in an emergency department setting, right? So you could do it orally, you could do it via intravenous injection. Sumatriptan. So we go to this one first because it has the most data and it's been out the longest. So just a little bit quickly about that. Here's the IV approach. And then we tend to avoid opioids, and we tend to avoid butalbital. Butalbital, kind of the old Fiorinol, Fioricet, Esgic medications. We avoid those now. They've been associated with congenital heart defects. So now the triptans have taken a step above the butalbitals and the opioids in our hierarchy of treatment. So quickly through this, sumatriptan was approved in 1992, so it's been around a while. All right, this is not new, and so we have a lot of information on it. Triptans are commonly used by women during their pregnancy, and I'm not going to go through the details here, but I will tell you, study after study really shows a very good safety profile. So maybe the old triptan registries, which were done in 4 countries, the US, Canada, Sweden, and Denmark, came up with nothing except maybe small birth weight. If you look at a meta-analysis of a number of almost over 4,000 exposures, you see that that showed an increased rate of maybe miscarriage. But interestingly, in the women who didn't treat with triptans, they had a higher rate of malformations. So you wonder, you can speculate, say, okay, were the miscarriages, were the spontaneous abortions problematic pregnancies that the triptans tipped the balance? I don't know. But it's an interesting outcome from that meta-analysis. Prospective studies, no significant differences in a number of outcomes for the baby. Norwegian mother and child cohort study, same thing, no neurodevelopmental abnormalities at 5 years. So this is the way we approach it. First line for prevention, low-dose aspirin. Really good data that it's safe, 81 milligrams. There's no reason that we couldn't try it if we need to do something, or beta blockers. So those are both considered to be safe. Second line agents, so if you have a lot of headache activity or you can't take those, pericranial nerve blocks, again, my advocacy for that, use those, they're very helpful. Occasionally low-dose amitriptyline. And so finally, the concluding remarks as we have now wrapped this up. Here you see the revolution as it's changing, and the final comments from Dickens. I see a beautiful city and a brilliant people rising from the abyss. I see the lives for which I lay down my life, peaceful, useful, prosperous, and happy. I see that I hold a sanctuary in their hearts and in the hearts of their descendants, generations hence. It is a far, far better thing that I do than I have ever done. It is a far, far better rest that I go to than I have ever known. So I'm not sure this is the best thing I've ever done. I hope you guys have learned something from this, have enjoyed it. So we'll move on to, I'm sure, bigger and better things, but thank you very much.